All right, can everyone see the title slide?
Yes.
All right, so I will begin and assume everything is okay until or unless I hear from you. And Dr. Juliet has given me the introduction, and I will talk about transmission of Mycobacterium tuberculosis or M. tuberculosis. So this is a map generated by the World Health Organization from 2018. It's the most recent one, showing the distribution of the incidence and burden of tuberculosis worldwide. And as you will notice, most of the burden of disease falls in sub-Saharan Africa and parts of Southeast Asia. And looking at this map really gives rise to a couple of interesting questions about the persistence of TB in some parts of the world and not others. So one of the driving research questions that I have and that we study is, why does tuberculosis persist in some regions around the world and not others? So I'm going to walk you through my the research studies that I've done in an effort to try to answer this. But before I go into the research, I just want to do a brief overview of tuberculosis disease by way of background. So TB is an infectious disease. It's caused by the bacteria Mycobacterium tuberculosis. Its natural history is different from what most of you are probably used to. Most of you are used to the influenza, the coronavirus, the common cold that you get exposed to. In a few days, you develop illness, and after a week, you're feeling better. TB has a very different natural history in that it can last the infection with tuberculosis can last a lifetime, and only a small proportion or fraction of people actually go on to develop the true disease. So we're all born into the world uninfected, and the risk of becoming infected is really determined by environmental and behavioral factors that expose an individual to an infectious case of TB. And if that contact is adequate, the susceptible person will become infected. Now, as I said, infection can last a lifetime, but some people will progress to full disease. And by that, the factors that affect the progression of disease are really not environmental or behavioral so much as they are factors relating to host susceptibility of disease, really the immune system of the person who is infected. So for today's discussion, I'm going to be talking largely about this first jump from those who are uninfected to those who become infected, and that's the initial transmission of M. tuberculosis. So just by way of theory or concepts, there's something that I call the replacement principle of TB. And what this says is, as long as one case of TB is replaced by another in a population, elimination of tuberculosis cannot be achieved. So here's a little diagram of a TB case in blue, has 4 friends, infects this friend, and that friend ultimately goes on to develop TB disease. So in the long haul, we haven't reduced the number of tuberculosis cases because this case infected that person who then became a case again. So this is an explanation for why disease persists in sub-Saharan Africa, for example. There's a lot of transmission going on that leads to new cases so that old cases are replaced by new. And if this case goes on to infect other people and 2 new cases arise, what you'll see is a sharp epidemic. Now, a corollary to that, or another principle, I call it the NextGen principle, and I'll skip my usual joke around that for the interest of time. But what this says is the next generation of tuberculosis cases is infected through transmission. The most important words here are before the diagnosis of TB is made and treatment begun in the infectious case. And this is true of all infectious diseases, at least person-to-person transmission. The transmission occurs before the diagnosis is ever made. So in this timeline, this is the TB case who becomes infectious at the beginning of the timeline, has all these contacts, and the red dots represent the new infections produced by this case over the course of time. At the moment of diagnosis and treatment, the number of new cases that occur are very few, and further contacts remain uninfected. But in the medical field, medicine is taught about diagnosis and treatment. They actually don't even think about all these new infections that occurred during the infectious period of that TB case. Now you can imagine if the diagnosis of that TB case were delayed for some period of time, you can see even more new infections occurring. And that is the problem of tuberculosis today, is that the transmission of TB that occurs before the diagnosis is creating the next generation of cases by infecting new people during this phase before the diagnosis. So delays in diagnosis of TB are very critical, but it's important to realize that the average duration of infection of TB prior to diagnosis, even in the United States, is 2, 3, sometimes 4 months. So people are doing a lot of transmitting before they even get to the diagnosis. So the research hypothesis generated from that question, the earlier question, is that tuberculosis persists in some parts of the world because transmission of TB goes undetected. And as a result, we're not able to implement proper prevention and treatment programs. So what I'm going to do today is review really 4 studies that date back to 1995. And so this really spans my entire career in studying tuberculosis. I'll talk about the household contact studies, social network studies, and then our current mobility and network studies. So the Coempe Community Health Study, which ran from 1995 to 2012, was a multidisciplinary study of tuberculosis in Ugandan households. It was based in Kampala, which in the lower curve here is, oh, I do have a laser pointer. There it is. So here's Kampala down here. This is Lake Victoria and Uganda. And if I blow up Kampala city, this is the metropolitan area of Kampala, and the work we did was in Coempe, which is just north of downtown Kampala. And this is one of the households that we enrolled in the study. And as you can see, there's a great deal of poverty, and there are actually 4 families that are living inside this small unit. The design of the study is very, very basic. The index cases we detected at the TB control program, and they were diagnosed and treated by the TB control program, and we assessed certain outcomes. But we went to the household of these TB cases and did what we call contact investigation, where we identified the household contacts of that TB case, and we performed a baseline evaluation with the tuberculin skin testing. And the purpose of the skin testing was to see whether infection was present or not. And then we further went on to evaluate for active disease, meaning did they have symptoms and signs of tuberculosis disease. I won't mention the cohort aspect of that study at this point unless someone has questions. Now, what we did that is, as far as I know, absolutely unique in the design of household contact studies is we identified community households to act as controls. And using those we evaluated those households in exactly the same way, using tuberculous skin testing and evaluating for active tuberculosis. So it's sort of on this cross-sectional aspect of the study that I base the results that I'm going to show to you. And there are many, many papers and many results, but I'm going to just hone in on these because they get to the estimation of secondary attack rates of not only secondary attack rates for TB disease, but TB infection. And I'll talk about progressive primary in a moment. So the usual approach to household contact studies is to estimate the secondary attack rate as the proportion of household contacts who had active TB. And in our study, it was 3% of household contacts when we went into the homes had TB disease. And that's very high. Other studies, might be 1%, 2%, and others in South Africa has been as high as 5 and 6%. You'll notice that young children have a higher risk for disease than older individuals, individual household contacts greater than 5. And you'll also see that HIV-infected individuals had the highest risk for infection in the household as compared to HIV-negative persons. Now, a unique aspect of this study was we estimated the secondary attack rate for infection. And for reasons that I won't go into now, but I'm happy to answer questions about it. This is not a simple parameter to estimate. But what we found was that the overall secondary attack rate for infection, so what that means is the proportion of household contacts who became infected by the index case during the infectious period of the index case was 47.4%, so almost close to 50-50, right? And you'll notice something very interesting. Children were at virtually the same risk for infection as adults. And HIV-infected individuals were at the same risk for infection as HIV-negative individuals. So this analysis calls into question some of the dogma that is out there in the TB world that says children are more susceptible to infection than adults. And HIV-infected individuals are more susceptible to infection than HIV-negative. Well, I believe that some of that confusion comes from what happens after infection. Some people in the household go on to develop, for all intents and purposes, an early case of TB. Those early cases are referred to as progressive primary disease. So this is what I calculate here is the probability of developing TB disease with the same strain as the index case, given new infection. In other words, given that they were recently infected. So that when we calculate that, so that's basically secondary attack rate for TB divided by the secondary attack rate for infection, it turns out that progressive primary disease is 6%. So following new infection in the household, overall, the risk of developing TB disease within about 18 months to 2 years was 6%. In young children, it was 10%, twice that in individuals older than 5. And in HIV infection, it was 18%, almost 4 times as high as HIV negative. So the highest risk groups here are the children and HIV infected. So to summarize those slides, what I would say is the household of an index case is an environment for intense transmission, secondary attack rate of close to 50%. The rates of new infection are high and do not vary by age. I have more age information that I didn't show, but that validates that. Primary progressive disease is most likely in young children and HIV positive contacts. So that was some of the main results of the household contact study. And as I would present these results at meetings and to students, I would often be critiqued, and it's good to be critiqued. People would often tell me that transmission in the household does not represent how most tuberculosis transmission occurs. And I was always puzzled by that question because it seemed to me that the household was the logical place where most transmission occurred. Furthermore, people said that most TB is transmitted in the community outside the household. And I always wondered, I didn't believe that. And I always wondered why people would say that, because at the time that this study was being critiqued, there was very little, if any, evidence to suggest that TB was largely transmitted outside the household. And the usual explanation was that there are more opportunities for contact between a TB case and a susceptible control outside the household, something called the mass action principle. Well, during the course of the study, remember, the study went from 95 up to 2012. At least 2 papers appeared while I was doing the study, one in 2004, the other in 2006, that indicated that only about 19%, and in this case 13%, of transmission could be in the household could account for infection in the community. A more recent one in Malawi was 9%. And then a former student of mine, Leo Martinez, and I did a meta-analysis type study where we gathered together data from multiple skin test surveys around the world, and we combined it together. And we estimated that the transmission attributable to household contact in the community was only 14%. So what does that mean? That means if you could eliminate transmission in the household of TB cases, get it to 0, you'd only see the level of infection in the community drop by 14%, meaning that there's still a lot of transmission going on. So as the years went on, and I read these studies and internalized them, and especially when Leo and I did this, I began to convince myself that I needed to look outside the household. But it was difficult. How do you look outside the household? Because it's hard to frame that. Well, after some time, I decided to use a social network approach. And we did what was called the Community Health Social Network TB project in Uganda from 2012 to 19. And my colleague Noah Kiwanuka is the co-PI, and we worked in this lovely hospital setting in Rubaga, Kampala, which is my previous one, Coempe study was here. Rubaga is an adjacent location in the city. Now, my hypothesis was that social networks account for most of the tuberculosis transmission in the community. So here's the household contact that I had just finished and the results I presented to you. And it accounts for 14% of transmission. So my thinking was that, well, of course, TB cases don't just stay in their home. They go to work, they go to church, they go to school, they visit friends, they go to the bars, they go to socialize. And in that activity, with their social networks, with their defined identifiable social network, they have contact enough in which to spread TB. So I figured, well, maybe it's much bigger for the social network than it is for the household. And that was the hypothesis of this study. It's very similar to the household contact study, where we had the index case and the neighborhood control. We identified the household contacts of both the index case And for sake of discussion, I call it the index control. But what's different from the previous study, the household study, is we didn't stop just at the household. We elaborated the full social network using social network methods that social scientists use to identify the extra household contacts outside of the community, outside in the community, for both the household contacts of cases and controls. And we, similar to the other study, we evaluated for latent TB infection and TB disease. So what did we find? Well, in the end, we had 123 TB cases and 123 index controls. We had 1,050 contacts of TB cases and 1,035 contacts of index controls. There were 400 household contacts of TB cases and 640 extra household contacts of cases. There were 225 household contacts of index controls and 810 household contacts of index controls. So already you see a little difference, right? It seems as though TB cases, there's more crowding in the households of TB cases. Now, what we did is we then did the tuberculous skin test, right? And we measured the prevalence of infection. Now, that's what this figure is showing, the prevalence of infection in household and extra household contacts. So let's start on the left side of this little dashed line. So these are case contacts. These are contacts of the cases. Sorry, these are the contacts, the 410 and the 640. 410, 640. And it turns out that the prevalence of infection in the household contacts here was 56%, pretty high. And the prevalence of infection among the extra household contacts of the index case was around 44%. Pretty high too. So if you did not have control population data, you might infer that these people experienced a lot of transmission by virtue of their exposure to the index case. Very important to have controls, because in the control households, we found that infection was even lower, around 30%. And it's lower here because of the children that were in the homes that were not exposed to TB cases. But look at the extra household contacts of controls, the risk of infection, the probability of infection in that group was 41%. I was very, very surprised at this. I expected this to be down here more around 25% or 30%. So I was very surprised. And if you look, it seems very similar to this percent as what right here. So it made me wonder, is there any transmission that's going on outside the household to the extra household contacts? If so, it's very small. In fact, it turns out to be only about 4%. So what we have here, what we concluded with this study is that there are two compartments for transmission. There's the household compartment where there's a lot of transmission going on. And then there's this extra household compartment where there appears to be transmission going on in the community. And the extra household contacts incur only a small increment in risk of infection compared to the community population. And this was a surprise to us, and this paper is now published. Dr. Corollary, who's in the meeting, was the lead author on that study and has actually managed the conduct of these studies over the course of the last decade. Well, we started to wonder why was this going on, and we wanted to take advantage of how we collected the data and we decided to do a social network analysis. A social network analysis is different from a standard epidemiologic analysis in a number of ways that I won't go into. Suffice to say that we used what is called ego-centric sampling, and we did it in an extended manner, kind of in a ring manner, from starting with the case, the household, the community, and so on. And using the using the social network data, we were able to construct a social network for the cases and the controls in the Rubaga community. And we used a variety of measures that were collected, and we used machine learning in order to come up with this representation of the social network in Rubaga division of Kampala City. Now, this social network, you can see it's pretty big. It includes the 123 TB cases, and in this particular analysis, we had 124 matched controls. There are 11,700 nodes or individuals in this social network, and there are 70,000 edges or connections between individuals, with the average number of connections per person being 10, with a minimum of just 1 and a maximum of 148. Whoever this person is, they're really, really connected to lots of people. So this shows the degree distribution, or basically how many people are connected. And you can see that this is 0, 50, and 100. There are not a lot of people with 100 connections, but there are lots of people with connections between between 1 and 25 or 30. So the median being 10. The clustering coefficient is 57, meaning that there's a lot of, this is a pretty tight-knit social network in this suburb of Kampala. With social network analysis, there's a series of statistics that are designed to measure the position of people in the network. And we were interested in knowing the position of male and female TB cases and whether men were more centrally located in the network than women. And the short of it is these 4 figures, as you can see, the women are in the red and the men are in this teal color. And for each one of these different statistics, betweenness, closeness, degree, and distance, they don't appear to be different. So the position of men and women in this social network didn't appear to differ very much. What we did notice is that men with TB, that's this bar here, are different than men without tuberculosis. In what way? They have less contact with children and more contact with men. Men in general have less contact with children than women. But interestingly, men without disease and women with or without disease kind of have a similar proportion of contact with men, and less than what you see among the males with TB cases. So what does this mean? That's called assortativity. It means men are spending time with men, and TB cases seem to be spending more time with other male TB cases. So there's some, cliquishness, so to speak, among men with TB disease. And we haven't yet discerned or determined the social factors that give rise to that clique. Now, we wanted to use another piece of information to help us understand the networks of transmission in the community. And to this end, we used the whole genome sequence of M. tuberculosis, which is, represented here. And I'll walk you through that analysis. Here's our overall network. And we used some network statistics to determine that there are 47 component networks. In other words, in that one large network in Rubaga, there are 47. I'm sorry, I'm getting paged here. Okay, that should stop that. So this large network had 47 component networks, meaning this one network, this big network that we saw comprised 47 individual networks. One of those, only 4 of those 47, so less than 10%, had more than one TB case in it. Obviously, this large component, this giant component, had 80, likely you'd imagine had multiple TB cases, and there were 85 TB cases in this. There were 3 cases in these networks, 3 or 4 networks. There were 2 cases in this component, and there was 2 cases in this other network. There's my pointer right there. We used the standard microbiology to assess the lineages of tuberculosis, and we had 63 isolates from lineage 4 and 14 from lineage 3. And the analysis that I'm going to show is based on these 2 lineages. You'll notice that we only had 79 whole genome sequences completed of the 123. There are all sorts of reasons for that, and it creates a certain type of selection bias that unfortunately we can't do anything about, but describe as a potential weakness of this study. So in lineage 3, this is lineage 3 on the left, lineage 4 on the right. And the red lines indicate that the molecular sequencing of the strain in one case compared to the next case was very, very similar. The blue means that it's sort of similar, and other than blue and red, we can ignore it for the purposes of this discussion. So you can see there's this cluster of 4 cases here that had that were pretty tightly related using the information obtained from the organism. And you'll see in a minute, you'd expect those people to be in the same social network, right? Same organism, same social network. Here's blue, less tightly aligned. And in the lineage 4, we have a number of pairs of TB cases that are tightly combined. Here's a cluster that seems to be pretty big with similar organisms, and another larger cluster here and some other dyads. So these were the ones that we were interested in, because our hypothesis was that if the molecular sequence of the organism was similar, that we would expect there to be recent transmission, and people would be, we could identify the networks that they were in. So if we were to count all of the clusters from I think this is lineage 4, there are 12 clusters represented here. There are 23 pairs. If I deconstruct those 12 clusters into pairs, there are 23 pairs with genetic links defined as a SNP difference of less than 12 between the isolates, meaning they're very, very similar. Only 3 of the 23, or 13%, were within a social network of one another, with a path less than 2. 13 of the 23, or 57%, had no identified social network path between them at all, despite that large network that we had. 2 people, 2 cases with strains that were almost identical and that we would believe were transmitted between one another. We can't make a link between them. according to the social networks that we measured. Now, remember, we work really, really hard to get these social networks. And despite that, we can't connect these folks. I'm going to quickly go over this. And the point here is just that only a few cases could we link. The majority of TB cases, we could not identify the links within the social networks. So that raises the question that we didn't measure the social networks very well, or there is something that goes beyond the social network that's important in the transmission of tuberculosis. Now, to try to get a handle on that, we calculated the population attributable fraction. Most of you know what that is. And we were looking at what proportion of infection in the community could be attributable to household contact, or to extra household contact, or to social network contact, which was either household or extra household. And you can see that if we just take into account recent exposure to TB, only about 7% of infection in the community can be accounted for by recent exposure. 5% from household exposure, and only 1.8% from extra household. If we go to all contacts, whether it's recent or remote, we ask people, did you ever know someone with TB, i.e. remote tuberculosis exposure? It does bump up to 11%. But that means that 90% or 89% of infection in the community cannot be attributed to transmission within the known social network of a person within their lifetime. Now, there are limits to a person being able to describe their social network over time, memory being one thing, but this is not a little, it's not as though we're at 80% of people being able to identify their social networks, and that social network accounting for infection. This is really low. I don't think any error that we've made in our study would raise this to 90% or even 50%. So it really does show or raise the serious question about where do we stand. In the interest of time, I'm going to skip this one and come to the model that we're working with. That we have the household network that we understand and we believe transmission occurs there. There's a little bit of transmission in the social network outside of the household, but between the household and social network, we're only accounting for about 11% of infection in any community. That means that there's this large amount of infection or transmission of M. tuberculosis that's occurring in this uncharacterized or undefined compartment within the community. And this is what I refer to as the contact network. Now, obviously, social network and household network are part of the contact network, but the difference is that the TB case is able to identify the household network and the social network. They're not able to identify the full extent of the contact network. So that's our interpretation of the molecular data and the social network data. And it means that most of the transmission is occurring out here in the community, and we don't know where that is. So that led us to this study that is referred to as the Mapping Tuberculosis Transmission Study, or MATS, and we're in the middle of that now. We're still at Rubaga Hospital. This is that map of Kampala, slightly different. We're working in Rubaga division and Kawempe division. And these are just some nice pictures of Kampala. This is electron micrograph of M. tuberculosis. And this is what's called a taxi park. This is where people go to wait for taxis to get transportation around the town. And here's a kind of a typical street where that's quite congested, lots of people on the street and lines of cars moving to and fro. So you can imagine there is a lot of mixing, a lot of contact that may be going on unrecognized by the index case. So in this study, we are collecting 300 cases. We're assessing their social networks and their geospatial networks. And we're collecting the mobility networks by obtaining cellular telephone metadata. And this is data prior to the diagnosis of TB, usually 3 to 6 months prior to the diagnosis of TB. And we're going to understand the microbial networks similar to what we did before using the whole genome sequencing. And this is the plan. The interviews give us the geosocial networks. Cell phone bit metadata gives us mobility networks. And the isolate of MTB, genotyping, and whole genome sequencing will give us the genotypic networks or clustering. This constitutes the epi data. This is phylogenetic data. And using some Bayesian modeling, we hope to develop what will be a transmission map. So these are in the first 73 cases of TB. These are self-reported geolocations where people spend their time. This is the metropolitan area of Kampala, and Rubaga, as you may remember, was on this side. And you can see we have quite a number of people these are the locations where people say they spend their time. So some people are obviously venturing outside of Kampala, as you would imagine. If we do a heat map of that previous slide, you can see there's a hot point here and here. This is getting close to downtown Kampala. There's another hot spot here, more centered in Rubaga. There are a few other hot spots around where people, remember, these are TB cases where they spend their time before TB diagnosis. So it's sort of a surrogate marker for transmission where they spend their time. So you might expect there's a lot of transmission going on here and here and here. To give you a sense of what these places are, and on the left-hand side, this is showing their purple and blue dots here. And this is showing the home, I think, is in purple and the workplace is in blue. And it shows distribution of where people live and where they work. And not surprisingly, most people work not too far from where they live. These are the taxi and bus stations. I gave you the example of that. And you can see they're scattered around and people move from their home to the bus station that will take them somewhere around the city where they might need to go. Now, we also have mapped out where the bars are. And you can see there are bars kind of scattered around. There appears to be a cluster of bars where people spend their time, TB cases spend their time right down here. So we're gathering this information, self-reported geolocation information. But we also are gathering the cell phone information. So this is a comparison of the self-reported locations here in red and the call detailed records from the mobile phones or cellular phone. Call detail records are just, it's the metadata that includes what cell tower was used to make the call or send a text message. And it's time and date stamped, and we're able to record that. And you can see visually, there's a pretty good concordance between them with a high concentration down here in central Kampala, and then a little, then it kind of diffuses out, more diffuse out in the outer part of Kampala city. The dots here, I know they're small, maybe difficult to see, but these blue dots seem to be more evenly distributed than the red geolocations. And the reason for that is that this is mapping the towers. And the towers obviously are spread apart to get the maximum coverage, where the self-reported locations are the actual locations that patients brought us to. So there seems to be good concordance between the two. Now, this is just an analysis of the pure call detail records, cell phone records. So there are 494 unique tower locations in Kampala that we have picked up on. The median visit per location is 2 patients. But there are 360 of these, or 73% of these locations, 1 to 3 TB cases has gone into that area near the cell tower. In 96 locations, or 19%, 4 to 8 TB cases have been within that, within a range of that cell tower. In 38 locations, there were 9 to 18 TB cases within that cell tower. Now, what we're in the process of doing is looking at the self-reported locations within each cell tower to find out how many of these 9 to 18 TB cases were actually in the same geographic space, same location. So we're honing in, and here the red represents the 38 locations, the yellow represents the 96, and the green represents the 360 locations. Now, this you've seen before. We are in the process of, we have the geolocation data, we have the mobility networks. The clustering data is at our fingertips. I'm waiting for it, and we're just about ready to do this. And I hope we'll be able to generate a map that looks something like this, where this is Kampala City. There's some areas that have a lot of transmission, some that have moderate amounts of transmission, and other areas that have very little transmission. So I would refer to these peaks as transmission niches that are, and I define that as geographically defined settings and locations where transmission of TB occurs. And since TB transmission cannot be observed, you can't observe transmission for any infection, we use time spent in a location as a surrogate measure for transmission. And we see that there's variability of transmission by niche. There may be high transmission niches, places where the TB patients spend lots of time, where there may be lots of transmission, and other areas where they spend very little time for transmission. So that's what we're expecting to see. And the research question that comes is time spent in high transmission niches associated with incident tuberculosis infection? Seems like it would, but no one has ever done this before. No one has ever mapped high risk settings the way we have in the previous study. Well, it turns out that we are doing a study called Capturing New Tuberculosis Infection in African City. We refer to it as the CAPTURE study. This is a busy slide, and I think I'm running out of time. So I'll just shorten it to say that we're trying to determine whether time spent in high transmission niches is associated with incident tuberculosis infection, and to determine whether there are geographic patterns of movement that are associated with incident infection. We're doing this in a cohort study where we take uninfected adults, follow them every 3 months, and measure for new infection, and we're tracking their mobility with GIS watches. This study is just recently underway. We have about 100 people of these 1,200 enrolled, and we're just placing the watches on folks now. A year from now, I'll be able to give you a lot more information about this. But I wanted to give you a sense for what we were doing. So imagine this, imagine a person has this trajectory during the day. They leave their home, they go out, and this area is mapped as a high transmission area. And during that day, they spend time and they move in certain parts. And we will be able to measure using the GIS watch how much time they spend in the low transmission part of this area, how much time they spend in this higher transmission part. And then the next day, they spend a lot of time down here. They're moving all over. Nevertheless, we'll be obtaining coordinates every 15 minutes or so. We'll be able to determine how much time they're in high transmission locations versus low. And if we look at day number 3, they spend a little bit of time in a couple and transit this very high transmission. And so you can imagine for each person, we'll be able to quantify the amount of time they spend in these high transmission environments, and we will relate that time to the risk of developing new tuberculosis infection. If we can do that, then we're kind of closing the loop. We're able to actually demonstrate that time spent in these high transmission locations that we've mapped is a way to measure transmission in that portion of the contact network that we cannot identify using information from the index case. So to wrap up, M. tuberculosis is transmitted via the respiratory route to susceptible contacts. The household of an infectious case is an environment for intense transmission where new cases of infection and disease occur. Contact tracing within known networks may have only minimal impact on transmission and burden of infection in Africa because the population attributable fraction is quite low. Novel methods are needed to map transmission niches in Africa, so public health interventions may be designed for these sites. Our next steps are to refine the estimates of transmission niches using new layers of information. We talked about social networks, geographic networks, cell phone and bacterial information. There are other things that we're interested in. We'd like to look at the incident tuberculosis as reported in the National TB program. We'd like to include population density as measured by satellite imagery. We'd like to measure the prevalence of HIV infection according to parish as reported by the HIV program. We'd like to use population movement as determined by aggregated cellular telephone metadata and perhaps others that we might think about. We would add this to what we already have to see whether we can refine and improve our ability to map the high transmission niches, the areas where one would expect to find TB cases. We'd like to define a transmission coefficient using the concept of transmission niches to quantify risk of transmission in geographic locations in the city. And I've already begun to do that even in our discussion. I'd like to develop a mixing coefficient to measure the amount of mixing between infectious cases and susceptible persons using cellular telephone metadata. And those methods have yet to be worked out, and that's kind of a research direction. We'd like to design and test community interventions for M. tuberculosis transmission using these parameters and maps and determine whether those interventions can actually improve tuberculosis control in the city. So with that, I have lots of people to thank, and particularly Noah Kiwanuka, who's the PI there in Uganda, Sarah Zawango here, who really runs the team, the field team, many other people, Dr. Sakandi, who's been working with me for a long time, Robert Kakairi manages the study, and without him, this certainly would never have happened, and many other people that have contributed to the success of our project. So I know, Juliet, I've gone over by 4 minutes, but I know we started a little late. Happy to take any questions.
Thank you so much, Chris, for that excellent presentation. Very, very comprehensive. And I maybe will let maybe one person ask a question if there's one. Put your question in the chat, or you can just go straight away and to the mic and ask.
I have a question.
Yeah.
Who else does? I can ask Dr. Whalen a question any day, so I don't mind if someone else has a question. Yeah, I was just wondering, just thinking back to that early slide, it's just striking to see orders of magnitude of difference in the burden of disease around the world, and what, based on your work and knowledge of TB, what do you think might explain those geographic differences on a large scale? I was thinking, how much of it is due to HIV and how much is not, and what are some of the other major actors, risk factors?
What explains the greatest variability is explained by GDP, as I was saying the other day. Wealthy countries, I think there's a general effect of better housing, better nutrition, better healthcare, better public health programs that incrementally and together have an impact in reducing the number of new cases of TB. And I believe once you get below a threshold of TB cases, it becomes easier to drive it down and lower the prevalence and incidence of TB. But when it's high, you just can't get control of it. And that's what it is in much of Africa and parts of Southeast Asia. The incidence is just so high that the current efforts are not identifying the new cases fast enough to drive the R naught down less than 1. That's what it really boils down to.
Thanks.
All right, so with that, we want to thank Dr. Whalen for the presentation, and thank you all for coming. Please come again. September 30th, we'll have another presentation for our seminar.